Hello, my name is Troy Henning. I'm the medical director for sports medicine at Swedish Sports and Performance Medicine here in Seattle, Washington. I was asked to review the diagnostic ultrasound of the posterior hamstring region. We're going to review the anatomy of the area, starting off primarily with the hamstring origin, talk a little bit about the ischiocondylar head of the adductor magnus, look at the ischiogluteal and biceps femoris bursa, as well as the adjacent sciatic and posterior femoral cutaneous nerves. Here, this anatomic model here shows the relative origin of some of the relevant tendons of the region that we're going to look at. So just to orient you, this is the pelvis here. It's facing us looking at it from the posterior aspect. Here's the ischial tuberosity. The blue kind of oval here is the origin of the ischiocondylar head of the adductor magnus. This red circle to oval type structure represents the conjoint tendon, which is the origin for the semitendinosus, as well as the long head of the biceps femoris. And then anterior and lateral to that type structure, which represents the origin of the semimembranosus tendon. Here's an anatomic specimen to help further delineate the anatomy for us. For your reference, top of the screen will be cephalad, left is medial, and right is lateral. Number 1 here shows us the sacrotuberous ligament. 2 is the ischial tuberosity itself. Importantly here, take note of the structures coming off the ischial tuberosity. So here you see the muscle of the semitendinosus. It arises somewhat directly off the back of the ischium, along with the conjoint tendon. And then this is the conjoint tendon here. Again, that is the origin for the semitendinosus and long head of the biceps femoris muscle. If you look closely here off the conjoint tendon, you'll see the long head of the biceps femoris muscle arising from a superficial and lateral position relative to the conjoint tendon. Moving back medially here, you'll see the origin of the adductor magnus. As you know, there's an ischiocondylar head, as well as a pubic origin as well. And then moving back laterally here, this number 4 is the piriformis muscle. Deep to that is the sciatic nerve. And then anterior to that would be your superior gemellus, obturator, internus, inferior gemellus, respectively, followed lastly by the quadratus femoris muscle. Here the specimen is laying on its side. Top now will be medial, right is cephalad. Here, this oval to round structure represents the footprint for the conjoint tendon, which has been reflected off here and sitting laterally. Here you'll see the crescent type shape of the semimembranosus tendon. Note its long tendinous portion, with the muscle again arising eccentric and medial relative to the tendon. You should also note that the tendon itself is rotating in a lateral type direction from cephalad to caudal here. And then again, you can see the origin of the ischiocondylar head of the adductor magnus muscle, as well as some of the muscle and tendon arising off the pubic bone. This picture down here shows, again, the footprints of the conjoint tendon, which is more of an oval to round type structure. It sits a little bit more posterior, if you would, to the crescent-shaped origin of the semimembranosus tendon. Here we see 2 bursae. So overlying the ischium is the ischiogluteal bursa. Imagine the gluteus maximus sitting here. And then this ischiogluteal bursa would be between the gluteus maximus and the ischial structures. If you were able to separate the conjoint tendon from the underlying semimembranosus tendon, in between is the biceps femoris bursa. On ultrasound, bursa appear as what I like to refer to as a reverse Oreo cookie. So the outer white or hyperechoic region represents the peribursal fat, and the inner dark region represents the synovial tissue of the bursal tissue. This specimen here shows or depicts a space or relative gap between the conjoint tendon and the ischiocondylar head of the adductor magnus. So at the time of imaging, you'll note kind of a relative bare area on the back of the ischial tuberosity, separating the conjoint tendon from the conjoint tendon, or from the ischiocondylar head of the adductor magnus from the conjoint tendon. This specimen shows the adjacent neurologic structure. So right is cephalad, left will be caudal. Here is the sciatic nerve, and then the adjacent posterior femoral cutaneous nerve that rises from a relatively deep position, and then it'll move superficially over the back of the biceps femoris. This will run down the posterior thigh, somewhat opposing the point of the sciatic nerve. Also take note of this recurrent branch here coming off the sciatic nerve. That's going to innervate the tendon and the bursa of the ischial region. I like to think of hamstring tendon injuries in one of two ways, traumatic as well as tendinopathic. So as we know, traumatic injuries are acute injuries that can be partial or full thickness or avulsion type injuries. The classic mechanism is the water ski type injury where there's force flexion of the trunk up on a force flexed hip. This can also be seen with slip and falls. So someone falls with their feet moving out in front of them, and they have a hyperflexion moment at the hip with the trunk coming forward too. And on occasion, someone will be loading the hamstring complex eccentrically, such as when doing a deadlift. Tendinopathy is more of a chronic kind of or insidious onset type issue, where there is some over or underuse of the tendon region with a sudden change in activity level, kind of pushing them in the wrong direction and with development of symptoms. The patient typically presents with pain at the level of the ischial tuberosity or the proximal hamstring region. They'll typically be sitting in the exam room, either in a chair or on the table, sort of off weighting that side. So they're sort of sitting askew in the chair or on the table, not really wanting to put weight through the ischial tuberosity. They'll also report not wanting to sit in a deep chair or a soft chair, because this also would cause them to sit primarily on the ischial tuberosities and or stretch the hamstrings. Sonographic evaluation typically is performed with the patient either lying prone or side lying. If you're going to lie them prone, you may underneath their lower abdominal or pelvic region to help cause some flexion at the hip to help reduce the anisotropy that will occur in the region, because when they're laying prone, the hamstring or the hip is going to be somewhat extended or on slack, and so that will induce some inherent anisotropy. So if you slightly flex them at the hip, this will help reduce some of that problem. Having the patient lie side lying with this hip slightly flexed with the involved side up would also be another way to work around this problem. Typically, we'll start with a linear transducer. Because of the relative deep nature of this location, you might have to move to the lower end of the frequency range of that transducer. Then I often open up the field of view a bit using a trapezoidal view. This just helps me gain a larger field of view and helps me orient myself better. On occasion, you'll need to move to the curved linear transducer for those patients where it would be more deeply located. Most of the scanning will occur in the short axis or axial plane relative to the tendons, where we'll assess the bursa, the tendons, as well as the adjacent neurologic structures. Long axis views or in the sagittal plane will primarily be used to confirm and further describe the injury, such as measuring tendon tears or avulsions, etc. There's a couple of videos I'm going to show you today. I'll try to go through them slowly with you. Most of them are oriented similarly. So the top of the screen here will be superficial, the left is lateral, the right is medial, and the bottom will be deep. Here's a view, short axis view of the conjoint tendon. This area here is the ischial tuberosity. Overlying it is the conjoint tendon, and then overlying that is the ischiogluteal bursa, followed by the gluteus maximus muscle. As we scan through the area, I'm constantly having to heel toe and wag the transducer to help overcome the anisotropy that is inherent in this area. You should also note that the tendon arises from a relatively posterior and somewhat lateral position. Also take note that the first muscle tissue that you see here arising off the tendon is actually the semitendinosus muscle. On the right image here, this is a long axis view. The left side will now be cephalad, right is caudal, top is superficial. Again, we have the overlying gluteus maximus muscle, ischial gluteal bursa. This is the conjoint tendon, followed by the ischial tuberosity here. Again, as we're scanning in long axis, I'm moving from a medial to a lateral direction, heel toeing and wagging the transducer in order to overcome the inherent anisotropy that will plague you in this area. This video shows the view of the semitendinosus as well as the biceps femoris muscles arising off the conjoint tendon. So again, superficial is top, left is lateral, right is medial. I'll let this play through a couple of times and then slow it down for us. Here's the ischium with the conjoint tendon, semitendinosus muscle with the biceps femoris adjacent or lateral to that. Semitendinosus, biceps femoris. Remember that the semitendinosus muscle arrives somewhat off the ischium directly, and then will be the first muscle arising off in a relatively superficial and medial direction from the conjoint tendon. The long hair of the biceps femoris arises more caudally and in a superficial and lateral direction. Here is the semimembranosus tendon origin. Again, it's a crescent-shaped origin, anterior and relatively lateral to the conjoint tendon. It is challenging to look at this area, especially proximally, because it is so lateral. It's sometimes hard to get the transducer heel-toed in enough to get a good look at the proximal aspect of this tendon. Again, to orient you, here is the ischial tuberosity with the overlying conjoint tendon. The semimembranosus tendon will arise again from this anterior and lateral relative position off the ischium. So here it is here, it's anisotropic. It's going to be deep to the semimembranosus muscle here. It has this tadpole type shape, and it will course again from a relatively lateral, superior lateral direction to an inferior medial direction. Again, remember it's rotating on itself laterally. Here's a little bit clearer depiction of this. I'll let this play through a few times. So again, top is superficial, left is lateral, right is medial. This is the semitendinosus muscle. This is the semimembranosus tendon. Here's the ischial tuberosity, semimembranosus tendon. Here has this tadpole shape, rotating on itself laterally, with the muscle belly arising off it medially. Semimembranosus tendon, deep to the semitendinosus muscle, coursing inframedially, rotating laterally. There's an important structure within the semitendinosus muscle, which can be confusing for the novice ultrasonographer. It is the raphe or an aponeurosis within the muscle. It moves from a relatively proximal medial to infralateral direction. I'm going to slow this video down here a little bit for us. I want you to take note into the semitendinosus muscle here. You're going to see a relatively hazy white structure right here come down and move from a relatively superficial and medial direction to an inferior and lateral direction here. And that often is mistaken for the origin of the semimembranosus muscle, when in fact it's just a raphe within the semitendinosus muscle. If you look at the 3 o'clock position relative to the semitendinosus muscle, you'll see another muscle arising off here just past the raphe. This is the semimembranosus muscle. So semitendinosus muscle, the raphe coming through here, and then the semimembranosus muscle arising off the off its tendon in a medialized direction. So Raphe, semimembranosus muscle, semitendinosus muscle, Raphe. Here's the semimembranosus tendon down here. Here's the Raphe, and then here's the semimembranosus muscle. Recall that the adductor ischiochondral head of the adductor magnus arises off a relatively medial location of the ischium. So for reference, this is top is superficial, left is lateral, right is medial. This is the contour of the ischium, tuberosity here. Here is the conjoint tendon. I made it relatively anisotropic to make it easier to see. And then there's a relative bare area here between the conjoint tendon and the ischiochondral head of the adductor magnus. On average, these are about 8.5 millimeters apart. Now we're going to look at the adjacent neurologic structures. So again, top is superficial, left is lateral, right is medial. Here you have the conjoint tendon and the semitendinosus muscle, biceps femoris muscle, and this is the sciatic nerve here. So note the sciatic nerve is adjacent to the ischium and the origin of the conjoint tendon, and then it'll run down the back of the thigh, living deep in between the semitendinosus muscle and the biceps femoris muscle. Recall that the nerve on short axis has a honeycomb type appearance. Going to back it up here a little bit, and so right about here, right here is the inferior gluteal artery. It's a relatively anechoic structure there, just to the right of the sciatic nerve, about the 330 position. And then overlying the inferior gluteal nerve is the posterior femoral cutaneous nerve of the thigh there, arising off and going over top of the biceps femoris muscle origin. So I'm looking in this plane here. As we go back and forth there, you'll see a honeycomb type structure moving from a deep and lateral position to a relatively superficial and medial direction, overlying the biceps femoris muscle. So again, sciatic nerve, inferior gluteal artery, and then this is the region where the posterior femoral cutaneous nerve is arising or moving from a relatively deep position to a relatively superficial position over the biceps femoris muscle. So this is the area here, right there. Moving on to two cases. This first case is an example of a partial tear of the semimembranosus muscle. So this person had slipped and fallen with their feet moving out in front of them and felt a pull or tear, pop, pain, and a little bit of bruising along the back of their thigh. This is just a still image here. So top is superficial, left is proximal, right is distal. This is the semitendinosus muscle here. Overlying that's the caudal aspect of the gluteus maximus. And then there was this relatively hypoechoic to anechoic region deep to the semitendinosus muscle here, which is essentially an old hematoma in the area. This is the video of that. So this is a short axis scan. Top is superficial, left is lateral. Right will be medial. Here you have the overlying gluteus maximus muscle. There was ischium, the conjoint tendon and semimembranosus muscle here, or sorry, semitendinosus muscle. And then deep to the semitendinosus, you see this anechoic region develop here. And that is that same hematoma in the region where the semimembranosus tendon should be. This is a complete injury, avulsion injury to the conjoint and semimembranosus tendons. This gentleman had got pushed over backwards, and again fell onto his buttock with his leg out in front of him, and felt a large pop, and developed an abundant amount of ecchymosis along the buttock and posterior thigh. Here you see a very large hematoma on this left image, basically enveloping the whole region. This is the semitendinosus muscle here, a little bit of the gluteus maximus overlying it here. There's mixed echogenic material surrounding this whole semitendinosus region here. This is a long axis view of that injury. Left is proximal now, right will be distal. This is the silhouette of the ischial tuberosity here, with a large gap, about 6.2 centimeters between the origin and the proximal end of that stump of the complex here. And this was confirmed at surgery. Here's a short axis scan down the thigh, just demonstrating how far distally the hematoma went, almost went down to the level of the knee. And lastly is an example of our report that we use. We describe the area that we're interrogating, the relative position of the patient, as well as the transducers that we use, and the reason that we're performing the exam. When we look at the area, we perform a complete exam, assessing the conjoint tendon and its muscles, the semitendinosus along here, the biceps femoris. We look at those structures all the way from the hip to the knee. And then we look at the semimembranosus origin, again looking at the muscle all the way from the hip to the knee. Follow the sciatic nerve out of the pelvis from its as far up as we can go, from the greater sciatic notch down past the level of the hip, as well as the posterior femorocutaneous nerve. And then we'll also interrogate the bursa to assess for bursal fluid. We'll describe our findings as well as try to make a very succinct conclusion. Thank you very much, and I hope this was helpful in you understanding how to interrogate this region with ultrasound.